Good morning, everyone. My name is Cassie Hopkins, and I help coordinate the webinars for Hausman Johnson Insurance and the Benefit Services Group. I would like to welcome you today to today's webinar, Better Results from a Better Understanding of Healthcare Data, presented by Andy Wire and Kevin Tripp. This webinar is interactive and will feature a question and answer session as well as polls. You can type a question in during the webinar and Kevin or Andy will address it during our question and answer session. After the webinar is over, there will be a short survey we are hoping you can fill out for us to give us feedback on the webinar and webinar topics you are interested in learning more about. This webinar will also be recorded and will be available on the webinar archive section of our website. Each attendee is going to receive a follow-up email with a link to the recording as well as the presentation slides. I would now like to introduce you to our speakers, Andy and Kevin. Andy joined BSGA in 2019 as Vice President of BSG Analytics, where he leads and oversees the entire team comprised of a data scientist, analyst, writers, developers, and programmers to innovate solutions to meet our clients' needs. BSGA is the innovative and analytical arm of BSG. BSGA provides a comprehensive set of analytical services to BSG and to our clients in Wisconsin and across the country. We continue to be on the cutting edge of analytics to foster development of alternative care delivery and payment models for ACOs, healthcare systems, carriers, and employers. This includes strategic consulting on a range of topics such as benefit design, benchmarking, renewal negotiation, stop-loss analysis, enrollment facilitation, plan administrative assistance and compliance, as well as analytical services which address rate development, budgeting, plan cost projection, plan design modeling, cost driver analysis, and reporting. Kevin Tripp has more than 15 years of experience in employee benefits consulting. His skills extend to strategic planning, data analysis, wellness, and implementing all lines of coverage for groups ranging from 500 to 20,000 employees. As an engaging speaker, he has created and shared presentations on how healthcare reform will impact employers and their employees for the next 10 years. He has also participated in multiple national exchange conferences throughout the United States, including Washington, D.C., Boston, Chicago, Las Vegas, and Milwaukee. Kevin recently used his extensive knowledge to successfully implement an on-site clinic. Kevin is a graduate of Carroll University, where he received a Bachelor of Science degree in Business Administration and a minor in Computer Science. He holds a Wisconsin insurance license for life, accident, and health. Welcome, Kevin and Andy.
Thank you, Rachel. Yeah, again, I would like to thank everyone for taking time out of your busy schedules to join us as we're looking at our Mission Impossible, but we believe it's a mission that's possible. And given our Mission Impossible theme, maybe we should look at our author's presenter's name here as Tripwire. But I'll bore you from any statistical humor that I picked up from 20 years of teaching statistics. So we'll kind of jump into it. So if you want to go to the next slide. So the mission really that we want to focus on is to make sure that you understand effective information is actionable, determinant, and defensible. There's a lot of data out there, and we need to turn this data into information and knowledge. We need to learn how to use episode treatment groups, we'll go over that, and episode risk groups to help turn this information into knowledge and wisdom. And then you're going to discover how using data analytics leads to better decision to help high-performing companies bend the cost curve, because everyone wants to have better outcomes at more efficient price. Next slide. So today's overall arching goals is our Mission Possible, to turn that data into information, and then our sequel is turning that information into knowledge and wisdom. Next slide. So as I said, there's a lot of data out there, and as a person who's working with data all the time, a bunch of numbers really don't do anybody any good. It doesn't lead to any results, and that's where we believe we can come in and help, turning all this data that's very overwhelming into information. As Cassie was saying in the intro, BSGA analytics, that's what we do. We transform data into actionable knowledge, working with our clients, which include the health systems, the employers, the insurance, member group policymakers, to provide this wisdom by working in tandem with them to improve the outcomes, resulting in better quality, improved efficiency, and lower cost. While BSGA was formally formed in 2012 as an affiliate of the Benefit Services Group, we've merged with Houseman Johnson in 2017. So you can kind of think of BSGA as the power behind, the analytic power behind Houseman Johnson. We know data, and I know a lot of people get scared away with all this information, all the data and stuff. It's just kind of mind-numbing. But we know the data. We know how to perform broad market studies using national and state data sources and proprietary system. Jerry Fry, our founder, is on the board of Wisconsin Health Information Organization, and I'm on the board and executive committee of the Wisconsin Collaborative for Healthcare Quality. So we're very in tune with what's happening in the state and in the nation. And we really take these systems and build robust data warehouses that our clients can use, so that it's not just a bunch of information that we're looking at. Next slide. So again, broadly speaking, just looking at one piece of information, one piece of data really is not very informative. So if you just focused on providers and you looked at patient experience, that's not going to help an organization move the needle. Really, we have to look at everything across the board, and we have to take all this data, connect it together, provide some synergies around that information so that we can move it up to the next level and turn that data into information. So we focus on the consumers, what their health status is, what their social determinants of health are. We focus on the providers, we focus on the payers, and we focus on the employers. So all this information needs to come together in order for us to develop that full picture. Next slide. Historically, the way people have tried to fix healthcare has been focusing on price. We like to say here, would you buy a car based on the price of a steering wheel? But that's what has happened. We tried to commoditize healthcare expenditure. We look at, well, what's the price of the MRI? And if we can only get the price of that MRI down, we're going to save everyone money. Well, the problem is that as you drive down the price of the MRI, maybe that's not the total price. So a place could have a low price to do an MRI than maybe another place, but now the organization that you're working with is going to charge a different fee to read it when it comes from another organization. So you got to look at the broader picture. And then historically what they've done is they've started to look at, well, the discount. If we can just get that discount price so that we get 10% discount across the board. Well, that starts focusing more on the total cost of care. We believe that this whole approach is kind of upside down. You really got to focus on the quality and efficiency and the cost of care instead of just focusing on that price. For example, the price of an MRI, maybe it's not needed. You probably don't need an MRI if you have low back pain. There's a lot of things you can do medically to see if the back pain goes away before you invest the money of an MRI. But if you're trying to diagnose brain cancer, you need that MRI. So it's not only just what item it's done, but it's how efficiently these items are carried out. Next, Kevin's going to kind of lead us through a discussion on how historically we've done this and how we've turned the data into information. And Kevin, so take it away.
Thanks, Andy. So one of the things I want to start with today is just talking about over the last 10 years, as Andy said, healthcare data is finally starting to get available to employers and health systems. So one of the challenges is that we've embraced this culture of data, and a lot of people have used it inefficiently or incorrectly, which has led to a lot of difficult decisions. So my intention is to give you some examples of how data is being used today, and really get into how it should be used and how employers can really have better outcomes and better results by working with a partner that actually understands data and can solve problems for the clients. So before we get into the data, one of the things that I think it's really important, and Andy kind of hinted at this before, is a history lesson for everybody today, is just how data can be used incorrectly, and it can lead to really bad decisions and bad strategy. So back in World War II, when Germany was attacking and bombing London, one of the big concerns that came up in London was, does Germany have guided bombs and missiles that they could pick and choose where they were going to have the bombing strike? So London hired some scientists to do a study in regards to, is this is this technology in existence during World War II, or is this just a random sampling of bombs and missiles getting struck? So they hired somebody, and if you go to the next slide, the first thing that the data scientists did is they drew it into 4 quadrants. And what you can see is that a majority of the bombing strikes and missile strikes were in the top left quadrant and the bottom right quadrant. Well, that was pretty eye-opening to England, because the top left quadrant, which is considered right around Regent's Park, that's a lot of the parks, the historical buildings, a lot of the museums, that kind of stuff. And the bottom right quadrant, that is actually the area that is all of the government-related buildings. So, England and London took a look at this and said, yes, they have to have guided systems. So therefore, we got to catch up to Germany. So what they did, they took this study and they spent millions and millions of dollars trying to quickly figure out how is England going to stop these or block these guided systems, and also how do we catch up to Germany? Well, after about a year or so of spending millions and millions of dollars, somebody took a different approach and said, what if we just change the lines? And what you'll see is that instead of going up and down across, they did more of a cross directional approach. And when they actually changed the lines, what actually happened is, you'll see, is this is actually a random distribution. And what they found out after spending millions and millions of dollars was that the data was right the whole time, and just that the context and the way that the scientists applied it was completely wrong. So what they actually found out after this was that it truly was a random sampling, and there was no radar guided or laser guided or any of that kind of stuff, specifications. It truly was just that they were flying over London and dropping bombs, and they would randomly spread across. So the point of why I like to tell this story is that we're going to talk a lot about having the data, and having the right data is very, very important. But it's just as important, or even more important, to make sure you're using it appropriately and correctly, so you can put yourself down the right path and not waste money that you don't need to spend. So what, in the last 10 years, what we've started to see is a lot of data where carriers, consultants, employers will report things like your PMPM cost, which is your per member per month or per employee per year cost, or any of those type of things. And, the next step that employers did is, well, I not only know how much I'm spending, but now I can focus on what type of care it is, whether it's professional, inpatient, outpatient, radiology. And what we'll do a lot of times is we'll benchmark that against the national population. But what's important to know about this is this can give a lot of false positives that I demonstrated before. The reason why is you're now comparing what your experience was in regards to what happened in the history, and compared it to what a large population that probably does not look like you, does not act like you, does not have the same population as you, that probably has just as many false positives as you do. So you are literally comparing yourself to somebody who could have terrible results. So instead, one of the things that we're going to talk about is, how do you actually tell whether the care is appropriate, whether it was efficient, whether it had a good outcome, and whether it was the right care at the right time. Another slide we like to look at is at things like utilization. So we'll look at how many times somebody went to the hospital, how many times somebody went to the emergency room, what is the average length of stay? We also throw out the average age of the population as a metric, and the higher the age, the higher risk you're going to have. Well, all these factors can be very, very distorted very easily. So the example I like to give is the average age. If I had a population that has an average age of 40, that could be that 50% of the people are 60 years old and 50% of the people are 20 years old. That has a certain risk characteristic of it. But I also can get an average age of 40 by having 100% of my population being 40 years old. What I can tell you is that the cost of that first group that has half at 60 and half at 20 is going to be about 70% more expensive than the population that is and everybody's at age 50. So once again, we've generically come out with stats and numbers that tell somebody a number and we act upon it, but realistically it's not getting to really what the driver of cost is, which in this case is that it's not a linear equation where older people, as you get older, that cost keeps getting faster and faster growing, whereas there's really not much of a difference between a 20-year-old and a 21 or 22-year-old, whereas there's a huge difference between a 55-year-old and a 57 to 58-year-old. Another big ticket item that's really important that everybody is focusing on is prescription drug or RX costs. And one of the things that's come out is that you've probably seen a lot of charts out there that will identify for you in regards to what drugs are being spent or what type of therapeutic category. And one of the things that it tells you is well, we're spending a lot of money on MS drugs, or we're spending a lot of money on diabetic drugs, or we're spending a lot of money on rheumatoid arthritis type of drugs or specialty medications. What it doesn't tell you is that are the people that are actually having these conditions, are they actually taking the drugs? Are they adherent or compliant with the medication? On top of it, it doesn't show anything in regards to what type of channel did the person pick up the prescription? Did they get it through a pharmacy? Did they get it through mail order? Did they actually get it through an injectable through the doctor's office? Because in today's healthcare, there is huge variances on not just the percentage of scripts that go a certain way or a certain channel, but really focusing on prescription A. Was it actually the best way to actually get the best price and best outcomes is by going through this channel? So the point is that broad data by itself can give you a direction. It's much more important today to actually have somebody who can summarize and give you the 3 or 4 recommendations of where you can actually make an impact to improve the health of your employees and operate your health insurance plan significantly better, not only over the next 6 months, but really over the next 5 to 10 years. One of the other key things that a lot of people talk about is, are my people healthy or not? So this is a chart that we've used for many years and gives you a high-level summary of what percentage of your population or this client's population has a chronic condition. And you can see, this population is growing from about 43 to 47%. So the logic is, wow, our population is getting sicker. And it also tells a little bit in the bottom right quadrant of how much we're spending on those members that have a chronic condition. Here's the challenge with it. What this will tell you is it's going to tell you that anybody who is a diabetic, what is the total cost of claims for that person who is diabetic? Doesn't tell you in regards to what's the cost of treating diabetes, what's the cost of the medication, of the insulin medication they're taking. All it tells you is that person X cost is this much and they're a diabetic. There could be a lot of other things that could be integrated in the health of that person. There could have been a car accident, could have been cancer, they could have had high blood pressure. So the point is that we can say that, hey, we're having a lot more people that are diabetic and the cost of the diabetics are this amount of money, but we really have absolutely no idea whether diabetes really is the driver of the cost or it's something completely different. So once again, we got at our fingertips all this data, but a lot of carriers, a lot of employers are going down wrong paths because they just don't have that actionable information to actually get to what the root cause is. So my last slide before I pass it back to Andy is just to give you another representation of how data can be misled. This is probably one of the most famous studies that came out about almost 10 years ago now, done by Pitney Bowes. And what they did is they had a decision or an idea and said, what if we made prescription drugs for cholesterol medications free? Would people take the medication more often? So what they did is they did a study over 5 years. And the top line you'll see is that these are the people that were taking the medication that they made the medication basically free. And the bottom line, the orangish color line, was that they charged $20. And what they noticed right away is that after year one, there was a huge difference between the orange and the green. So they made a decision that, over time that there is a large variance. So they came out and told carriers, told employers that make all your drugs, your preventive medications free, because that's the driver of why people don't take medications. I would give you a different analysis on how I would look at this report. What I look at is the bottom top right quadrant, that over 5 years, even though we made the prescription drug free, almost 70% of the people still did not take the medication. So yes, there is a difference between the people that got free medication versus the people that had to pay some, of about 20 to 30%. But what about the other 70% of people that were not taking the medication? That to me is a much larger issue than that 20 to 30% difference. So we've done some research, and one of the things that you actually find out is that the reason why people do not take statin medications is that when you take those medications, high cholesterol, high blood pressure, those type of medications, you don't feel different because you have those conditions. It's not like diabetes, where if you don't take your insulin, you're could go into diabetic shock. You don't feel well. You can get real sick. So you actually notice when you don't take the medication. Whereas in a lot of these type of medications, people don't feel differently in regards to, oh my gosh, I have high cholesterol. I feel like my heart attack is going to happen. What actually happens though is the medication does give some ill effects to the people. And two of the biggest complications for statins is muscle stiffness and not having flexibility. So when you actually look at the people and ask the people why they took stopped taking the medication, the biggest answer you got was males that were over age 40 was that it impacted my golf game and it impacted my bowling game. So once again, people weren't as flexible, they didn't feel as good, but yet when they took it or they didn't take it, they actually felt better not taking it. So what really should be the approach is not addressing the cost of the medication, is really an education campaign and explaining in regards to why not taking that medication over 5 to 10 years can have a huge impact. How people that are taking those statin medications should have stretching exercises and activities that they can do to actually make them take away some of the symptoms, so that way they can address the bigger issue. So instead, employers spent all this money giving away free drugs, and they still were missing 70% of the people, where they could have spent that resources and that money on actually addressing what was really impacting people in regards to why they're not taking the medications, and spent the money correctly and gotten the much better result of people taking the medications and feeling better. So with that, I'm going to pass it back to Andy to talk kind of about what, in regards to, now that I talked about, what the challenges are, how do you really get the results that you need?
Thanks, Kevin. Yeah, so like Kevin said, we've historically have taken the data, turned it into information around the PMPM, around the chronic care spending, but that's really only part of the picture. And as we're trying to look at developing the whole health benefit strategy, we need to look at the quality and the population of health, and then we need to focus on episodes of care, which we're going to get into in the next few slides here. So next slide, please. So now we're going to have a survey around a survey question here. We'd like you just to take a brief survey on what percentage of the health plan cost is driven, do you believe, by your plan design? So your co-pays and that type of information. So if you please could select answer, and we'll have a quick poll. All right, so it looks like most of you selected that you believe it was around 47%. And the next most popular answer is about 27%. And well, excuse me, the popular answer was 75%. I guess I was reading that wrong. Somebody who reads numbers all the time, sorry. So, all right, so as we look into the data, the plan sponsor really only drives about 6% of that total cost of healthcare for the system. Where most of your cost is driven from is around your employee health. So the basic of the employees and what their health conditions and everything else is really going to drive about 70% of the cost. Now the graph, what that's showing you in the background is that's all the type of data and information that is needed to really do a robust analysis and help figure out what's driving all the care cost as we look at this. Next slide, please. So when you look at what's driving the employee healthcare and what's driving outcomes in general, a study done by Wisconsin's very own Karen Timberlake, who used to be the Secretary for Department of Health, and she developed this work while she was at UW Population Health, looked at what's often called kind of the social determinants of health and what is driving the healthcare costs. And as you look at this graph, that overall health outcomes, if we look at length of life and quality of life as being how we're measuring the outcome, there's many health factors that will yield our different health outcomes. And even before the health factors, we got the policies and programs in place. But if you focus on the health factors, you can see that inside the clinic walls, that only drives about 20% of your results. So 80% of your results of your health factors are really determined by things outside the clinic walls. So that includes such things as health behaviors, do the people use tobacco, diet and exercise, social and economic factors, education, employment, income, and physical environment. So 80% is driven by a lot of these social determinants of health. That's why when you're looking at the wellness of your employees, you got to look a lot broader than just always focusing on the clinical care. That's an important component, but we want to make sure that we have a wellness activity. We want to make sure that we're addressing the full gamut of what's happening out there. So now what we want to do is really start looking at a better way of looking at these items. So instead of just focusing on the cost per member per month or focusing on if it's chronic or not, we want to start branching out and looking at a broader perspective. So we can do this by looking at episodes of care, risk adjustment, quality, efficiency, and total cost of care. Next slide. So what is an episode of care? You can think of an episode of care as taking what we have as that transactional data information. So if historically what we've done is, as the data has come in, many places have looked at, oh, well, we're going to stack all the professional cost over here. We're going to stack all the RX cost here. We're going to stack the inpatient cost here. We're going to arrange everything as it comes in, and then we can tell you that on inpatient, this is what you spend. On RX, this is what you spend. So like Kevin said earlier, is you can look at this information and sort of by diagnosis, and then you can say, if you're a diabetic, this is what you spend on a typical patient who has diabetes. But what we believe is more important is looking at the episode of care, is taking all that information that as it's arranged in the transactional system and really breaking it up and then grouping it by the episode of care. So now we're more interested in finding out how much does it cost to treat a diabetic patient, diabetic episode. So now we're looking at the factors relating to the diabetes care. Then we can start making those comparisons to see how the treatment of a diabetic patient varies from organization to organization and different plan designs, instead of just focusing on what an average, the total spend is on a diabetic patient. Or we can look at if it's a knee replacement, we can start looking at, well, gee, how much was that total cost of care across a knee replacement? And then we can adjust for severity. Next. So broadly speaking, an ETG is an episode treatment group. It's a basic illness classification that's used. We use all the data from inpatient, outpatient, professional, ancillary, and pharmaceutical expense. And it really helps us determine what care is being provided and how well it's working. Next. So broadly speaking, this is just an example of how you can determine what the ETGs of a diabetic are. So ETGs are first arranged in what we call major practice category, and you can think of them as main clinical system body parts. So diabetes would actually be under endocrinology. So if you look under endocrinology, then we have these ETG base groups, and there's 524 of those. And so it can be cystic fibrosis, dehydration, and diabetes. They're all part of endocrinology. And then as we get into each of the ETGs, there's over 1,500 of them. Each condition can have up to 3 factors that we looked at. It's whether they have with or without complications, with or without comorbidities, and with or without surgeries. So by the time you multiply all those together, that gives you 8 more different choices for each one of these. And that's how we can start diving into the data to look at what that ETG will look like. And then we can use that to start making adjustments to compare across organizations for severity. Next. Once we have these base ETGs, then we can start looking at the risk, and that's a measure of an illness burden. We can look at a retrospective risk or a prospective risk. A retrospective risk looks back at all the claims data to help determine what we would think that risk score would be, and a prospective would be looking more at demographic information, age, gender, sex, to figure out what the future risk will be. The risk score you can think of as a relative cost or units. A base one is going to be 1.0. If somebody had a risk score of 1.25, they would be 25% more risky or use higher, 25% more utilization. If someone had a risk score of 0.85, they would have a 15% lower unit of use. So we can use this risk information to really help drive what those costs are. And then once we have the ETGs, we have the risk, we can start looking at the price and then get a risk adjusted price. Next. Now what we're going to have is Kevin's going to kind of step through again, so how we take that data and information and really start turning it into knowledge and wisdom for our clients by applying this information with our clients' data and working with our clients. Kevin?
Thanks, Andy. So Andy gave a really high level for you in regards to the science and how we're able to actually get to actionable data. But one of the questions we always get is, wow, that sounds really complex. You know, how does this really apply to me as an employer or a system? So what I have for you is a quick case study of a real life example of how looking at episodes of care can tell a different story. So this is actually one of our clients, and you'll see on the bottom right section that we saw that about 6% in the very bottom, you'll see 6% of the people have type 2 diabetes, and 3.8% is the benchmark for type 1 diabetes. But if you look a little bit to the left, you'll see only 4% of the people have type 2 and only 0.8%. So that index is a 0.80. So what that tells us, when I first looked at the transactional data, is, wow, this employer has a lot less diabetics than what the marketplace is. So diabetes must not be an issue for them because they don't have that many people. So that's all the transactional data can tell us, is how many people they are, and like I mentioned before, how much we're spending on those people. So when you actually start looking at episodes of care, you actually, like Andy said, you're really flipping that data on its side to get a different look at it. Instead, I can actually now look at not only in regards to how much did I spend for the condition of diabetes, not the entire person, but I actually can tell in regards to what should I have spent for that condition. And what you'll see is, you can see the different categories, but on the very bottom, you can see the dark blue color on top is actually the client's non-RX, so the medical spend. And the bottom you'll see the lighter bluish color is the benchmark. So they're actually pretty close and slightly lower. So as a whole, they're doing a good job of actually spending, not comparing to what the marketplace is, but what they actually should spend based on the illness burden of that population. But where you start to see a huge difference is on the prescription drug side of things. You can see they should be spending about around $2,800 total, but they're actually spending almost $3,600 for diabetes, and that biggest variance comes from the RX. So the question is why? Is this, are they taking too much brand name medications? Are the people staying on the medications too long? Are the people taking multiple diabetic medications where they're not? So this is there different behaviors in regards to what doctors these people are actually seeing, whether it's family practitioners versus endocrinologists. So this once again gives us the next step in regards to, okay, we now know where the issue is, so what do we do about it? So the next slide is that we took the next step to see is the patients that actually are actually seeing doctors that are diabetic. Is there a difference in regards to what they're spending compared to what's expected for that person by doctor system? And you're going to see there is huge variances in the hospital system. So I kind of highlighted a couple of them, but look at provider 4. Provider 4, you can see the light blue and the yellow is only about $2,000. So that's actually not saying what the benchmark is, but that's saying that based on the illness, the age, what treatment, the conditions the person has, what should they be spending to be treated? However, when you look at the top part of the line, you can see this provider has huge expenses on RX. So that would lead me down the path that, man, this doctor is really overprescribing brand medications, or this doctor is doing way too much medication. So this doctor is not an effective use of cost for your diabetics. On the same end, you can see provider 8 is also that way, and provider 7 was a little bit closer. But on the same end, you can see provider 12, if you go down, is actually doing a really good job in regards to the RX spend. You can see it's much smaller. So this could be one of two things: either they're really effective and they're taking care of the cost very well, or it could be that people just aren't taking the medication and the medical claims are going to explode. However, since we're looking at episodes of care, we're looking over 3 years of data. So I can see the medical expense is still lower than what's expected. So this doctor is a prime example of a highly efficient, highly quality doctor. So the point of this is that episode of care, or that transactional data that we talked about at first, told us that we don't have that many diabetics and there's no issue with it. When you actually use episodes of care, you actually can get to a root cause in regards to where is the opportunity, and now we can create a strategy for employers in regards to how do we really help people understand who are the most efficient, most quality doctors, and how do we incent them to do this. So even though this was a lot of information behind the scenes, what we want to do, or what we try to do, is actually take all this information, do all the work behind the scenes, and come forward with 2 or 3 bullet points in regards to here's the strategy. Here's how you actually respond or can help your employees seek better care that actually improves their health and improves your spend, rather than overwhelming you with tons of data reports. So with that, I'll pass it back to Andy.
Oops, forgot to unmute. Thanks, Kevin. Now we want to focus on the unit price. Again, a lot of people will focus on that unit price, and we just want to continue to drive the idea that unit price does not always correlate with the overall total cost of care or the overall quality. This is an example of clients listed, care systems listed from left to right, of the ones that had the lowest unit price for an item. So that's just looking at that yellow line. And then the orange line that's going up and down is the total cost. So you can see that there are some people on the left-hand side, provider systems P, N, and H, who, although they have very low unit price, their total cost of care is very high. Conversely, on the right-hand side, you got provider groups B, Q, and R, who have, while they have higher unit price, their overall total cost of care is lower. So the whole idea is that we need to look at price, but we really need to look at the total cost of care, and we need to adjust it for the risk and catastrophic claims and look at a more complete picture. Next slide. So one of the areas that BSGA has developed to help look at provider efficiency is by looking at what we call our four-square analysis. So this display here is looking at the health systems in Wisconsin, and the overall, if you're in the right-hand, upper right-hand quadrant, that would mean you have high quality and high efficiency. So the efficiency is on the left to right, and the quality is up and down. The thing is, many Wisconsin provider systems are integrated. Previous studies have shown, and our studies have backed it, that integration itself can lead to higher quality and more efficiency. So while this looks like Wisconsin has some providers who are performing not as in the desired quadrant, this is all based on Wisconsin averages. So we base this on WCHQ's data, we base this on WHEO, Wisconsin Health Information data. If you go to the next slide, it's amazing the different perspective you can get if you go to national averages, how people shift. So I mean, I think that speaks very well that Wisconsin has many high quality and highly efficient systems. Next slide. So again, sometimes if you focus on a particular price or item, you can come up with the wrong conclusion. We helped an organization that was based in kind of central eastern Wisconsin, and they were looking at their heart care patients and patients who needed to have heart surgery. They had the option to send them to a system in the north, or they could send them to a system in southeast Wisconsin or northeast Wisconsin for care. At first, when they analyzed it, they said that the typical price of an open heart surgery in the north market was cheaper, therefore that was a better decision. As we helped them and looked at the data, what we found was that while the overall cost for open heart surgery was cheaper at the north facility, the south was a better option. Why was that? That was because that the south often treated more of the patients with angioplasty and a less invasive procedure instead of cracking open the chest. And by doing the stents and doing the angioplasty, they had better outcomes and they had lower costs, and employees were able to turn to work quicker and had lower length of stay. So again, it wasn't that the focus should be on how much does it cost to, even if you say the total cost of care of open heart surgery, the real picture that one should focus on is what does it cost to treat a patient who has this condition, and where do you get the best outcomes? Next slide. So we've done a lot of work looking at our total cost of care. And again, we believe that unit price is an important component of that, but it only drives about 17% of what we believe is the total cost of care. Much more of that cost of care is driven by efficiency, and around 22%, and even a higher percentage is driven by quality. We believe half of it is driven by quality. And then population management, engagement, again, organizations, provider systems really trying to look at the total population of care. That's another 11%. We've developed our indices to look at this. So even in this example where we've adjusted all the indices so that a lower number is better, even a place with a higher unit price, such as at 5% higher than market, can still come up being more efficient. So the idea is, again, as we look at information, you need to look at the data, you need to turn it into information, you need to work with the clients to take that information into knowledge and wisdom and really apply some scientific rigor around that to make adjustments where needed and apply things. So our team kind of gets to handle all the fun stuff, the logistic regressions or whatnot, and work with our experts here in helping our clients. Next, we're going to kind of have Kevin help wrap us up.
All right, thank you, Andy. So now that we've talked through kind of a lot of the intricacies and why our approach is a little bit different, and we feel that it's really the future of healthcare analytics, question is does it work? So the next slide really is that in summary is that data is really truly just the past tense. It can be just numbers. So by reporting what's happened in the past, can tell you what's happened in the past, but it's not going to be indicative of the future. So instead, like Andy mentioned earlier, is that we need to transform data into information, knowledge, and wisdom. At the end of the day, if we're just comparing what some national benchmark that doesn't look like you are acting upon information or data that really is not going to help you lead yourself forward in the next 3 to 5 years. So make sure whoever you're working with that is able to not just get data, but actually use it efficiently and effectively, and make it simple for you that you can actually get information and decisions to really keep leading you forward, so we're not repeating the cycle that we've been doing the last 10 to 30 years. So question is, does it work? And not to toot our own horn, this is actually our employer. So this is every employer that has worked with BSG over since 2002. We haven't cherry picked any in or out. This is truly every single employer. One of the things we wanted to see is, has our data-driven approach and our analytical approach actually bended the trend? And the very top line is what the average employer trend in the United States has been since 2002, and you can see that's about 5.2%. So it's grown about 5.2% every year. Medical trend, or CPI, is the green line. So that's what has inflation cost in regards to healthcare going up over year to year. So for example, if a doctor, you saw a doctor last year and he charged X amount, how much more did he charge next year for that exact same service? So medical inflation has gone about 3.3%. Our book of business has been able to actually beat medical trend, meaning we're actually spending, taking away medical trend and having a better result. So you can just see that our trend is 2.9% versus the 5.2% trend of the average employer. Now, like Andy mentioned, we do look at plan design and we do look at carriers when it's appropriate, but most of this ability has been just finding opportunities to make it easier healthcare, and better results for your employees and our hospital systems. So that way we're not just moving costs from an employer to an employee, which does nothing to solve the root cause. Instead, we're going to try to create strategies and opportunities to actually get better outcomes, better care, and better results for the employer and really for the employee.
All right, and at this time, we are going to open it up to questions. So again, a big thank you again to Andy and Kevin for presenting, and we have them on the line for you to ask questions for. So just type into that question and answer feature that we have here on the dashboard. Give everyone a couple seconds. All right, so we have our first question, and it is, how easy is it to get this type of information from carriers, and are they required to send it to us?
Sure, this is Kevin. I'll take that one. If you are a self-funded employer, this data is your data. So it's the employer data. So the answer is yes. Getting a data extract should not be an issue for you. The challenge is going to be is not just getting the data, but having a partner that actually can transform data extracts into those episodes of care and actually provide strategic consulting on it. So self-funded, very easy to get, and you should have no problem getting that. On a fully insured basis, though, it really depends on the size and how good of a partnership your consultant or your data partner has. So in the state of Wisconsin and really nationally, most fully insured clients, employers over the size of 100 can get access to that data. Now, there may be some challenges that you would need to work through, but we have had success for employers greater than 100 employees to get full data extracts because the hospital systems or the health insurance companies have worked with us for many, many years. Sometimes, though, you may not be able to get that information, but by having book of business information, having marketed information like Andy mentioned in regards to the hospital systems and the statewide databases, you can still get actionable data that will lead you to better results than having no data. So a majority of employers, this data is available. The trick really is that once you get it, knowing how to make it, doing the correct analytical approach, but really making it simple and actionable to really get to the cause.
Great answer, Kevin. Thank you. We have had another question come through while you were answering, and it was, how can you tell what is driving the increase in PMPM if looking at larger items such as your chronic spend if the disease group is not enough? I think that would be for you, Andy. Would you be okay answering that question?
Sure, I'll take a step. Really, it's looking at a much broader basis than just that individual PMPM. So again, it's trying to look at the episodes, trying to dive into what's driving all those costs, is how we can do that. So it's a lot of it's done behind the scenes, but then we can share and work with our clients on that. And Kevin, I know you've done that. You do that almost all the time.
Yeah. So one of the things when you talk about an increase, we have a insured carrier that gives me a 20% increase. One of the questions that most insurance carriers or HR people aren't able to answer to CFOs is why. What is driving it? And one of the things you need to be able to look at is it the mix of care? So did my care change in regards to it became more severity or more severe? Was it the mix of services? So we used to have X percentage of services that were in office visits. Now we're having more ER visits, or we're having more urgent care visits, or we're having more nurse practitioners. Did we lose discounts in regards to our unit price has changed and we're now paying more expensive for those services? So the point of it is that there is honestly no easy answer in regards to the answer is X. The answer is you need somebody that can actually look at all the data and pick out in regards to, okay, what is truly driving it? Is it illness burden? Is it how the outcomes the providers are actually providing to you? And trying to pinpoint that strategy. So then when you have only X amount of resources to use to try to combat it, let's be laser focused and get to the root cause that's going to have the most bang for the buck.
Yeah, good point, Kevin. And then even in addition, we've developed some even recent analysis that really helps do that initial focus without having to kind of relook at all that. So again, focusing around, is it change in the membership, change in the number of people who have the disease, change in the large claims, again, so that we can start to compartmentalize it and start looking at what some of those key drivers of that price change are.
All right, it looks like we do not have any more questions that have come through. Last call, going once, going twice. All right, and if you are on for HRCI credits or SHRM credits, we do have those available right below Andy and Kevin's email. If you think of a question after the webinar and you're like, oh shoot, I really wish I would have asked that, you are welcome to email either Andy or Kevin and they will be happy to respond to you. I want to thank you guys so much for attending today's webinar. Please remember to fill out that short survey as your feedback is very important to us. It helps us improve our webinars and also get subject topics for future webinars. We hope you can join us for our next webinar, which will be on how to establish a successful return to work program on August 29th. Thank you again, everyone, and have a great rest of your morning.
Thank you.